we have recently a study called CHAIN, Childhood Acute Illness Nutrition Network, where it was a multi-country study including Sub-Saharan Africa and Southeast Asia, where we found that those who died during the post-discharge period that don't only have the clinical problems, they also have the social problems, they also have the immunological problems, they also have problems of a lot of things like microbiota. So I don't want to focus all of them, but I want to let you know that the post-discharge mortality is not only associated with simple clinical things. It is a lot of things, there's social things that whenever a child go to home in his own environment, it is in most of the children who go to home after discharge, they are somewhere malnourished. They used to have called environmental enteropathy. When they go home to their own environment, they go back to that stage. And there are a lot of things like that. So I just want to know, I just want to inform you that post-discharge mortality is a huge burning issue for all of us. And it used to happen even though you can see that your child is completely recovered. So WHO recommendation is that even though we used to discharge this kind of children after going home, we should motivate the caregivers. If there is any problem, visible any problem, they should come earlier rather waiting at home. So why I'm giving the emphasis on that, visible clinical recovery might not recovery in future. We might need to perform some investigation, laboratory investigation, especially biomarkers during discharge to understand whether he or she is totally fit to go home. So other things that those who survive, you can see that they used to go through a lot of problems. Someone might not have adequate cognitive function in time, and they might not have good school performance compared to other their peers, and also they might have other comorbidity of the disease during the next stage of life. So these are the things that sepsis is not only the acute things, it is a thing for the future generation to think of, that we need to stop sepsis very early to have a very good quality of life in the post-discharge. So this is the things we need to say for all of you, that we need to identify sepsis very early to treat it very efficiently and to prevent those consequences, fatal consequences like death or consequences after discharge, even after full recovery. So sepsis is a syndrome which can occur at any illness. So we need to diagnose sepsis in a way. We need to have something, diagnostic criteria that we can, we should not miss the case of sepsis, and simultaneously it should be like that. We should not have children who have a lot of misdiagnosis. This is why we call it sensitivity. Sensitivity means that you should have that kind of diagnostic test that might be clinical or laboratory, that you can control, or if you can screen, if you can bring under screen almost all the septic patients with those criteria. And the specificity means that the test that you are doing, it is most, if you can confirm the diagnosis. So we have to make a balance. We used to know that if a diagnostic test is more sensitive, specificity used to less, but we need to find out this kind of criteria where there is a balance between sensitivity and specificity. Sensitivity may be much more high, but specificity should be nearer to this. So we wanted to evaluate our diagnostic criteria of sepsis by this way. And from that point of view, we wanted to go for the next step. So this is the very popular International Pediatric Sepsis Consensus Conference definition led by Dr. Goldstein, and it's published in Pediatric Care Medicine back in 2005. And still, till date, this is the only pediatric definition sepsis criteria. Till date that I found to mean that before January 2024. And if you see, this is based on eminence, not the evidence-based. And what we have found that here there's a special term called the SIRS, Systemic Inflammatory Response Syndrome. There are, among the 5 criteria, if you have the 2, then you can tell that this is a patient of systemic inflammatory response syndrome. And in case of systemic inflammatory response syndrome, if you can find any focus of infection, suspected infection, then you can categorize them sepsis. The limitation of these criteria was that it is not well validated, and even without the focus of infection, or without, given with the focus of infection, you might have a lot of false positive diagnosis. I can give you one example. In our center, we mostly entertain diarrhea cases. When a diarrhea patient comes, they used to come with dehydration. In case of dehydration, what occurs? That there is loss of volume, and during passing stool, there is loss of also bicarbonate in the stool. What happens? This due to passing of this bicarbonate, there is metabolic acidosis. Due to metabolic acidosis, lungs wants to wash out the carbon dioxide to compensate this, and as a result, there is tachypnea, and there is loss of volume. There is already tachycardia. So there is, although there is focus of infection, diarrhea, and there is still tachycardia, tachypnea, so there is sepsis. So all the children who come with diarrhea and dehydration, irrespective of presence or absence of sepsis, all should be diagnosed as sepsis according to this criteria. So this is the limitation of this definition. So we thought that although this involved almost all systems, major systems like the neurological system, respiratory system, and also hematological system, renal system, and also hepatic system. But the problem is here. Then what we have found in 2016, there is published article in JAMA where it has been shown that it is mainly based on adult, and they evaluated more than 1 million data where they showed that sepsis is a population, especially in adult, those who have actually life-threatening organ dysfunction, just caused by dysregulated host response to infection. And this is well validated in case of adult. And for adult population, this is a very unique definition. However, we were supposed to follow this definition, although we have Goldstein definition back in 2005. But this is sepsis 3, which actually persuaded us to follow this definition. But as you know, that it is not validated in children, as well as these data are mainly taken from higher income countries. And these data, there was almost nil data from lower middle income countries, especially those who are in the lower resource setting. So at that time, what we thought that we thought that we should, back in 2017, we those who are pediatricians from lower middle income countries as well as from high income countries who used to work with pediatric sepsis, there was a meeting among us, and we strongly felt that we should have study like adult, and not only involving the higher income countries, but also involving the lower income countries, where we need to understand how we can go forward with sepsis definition, which might be generalizable both for higher income countries and lower income countries. Although it is very intriguing, you might know, I am sure that all of you have a lot of questions. Although our aim was to generate a definition of sepsis for global, not only for lower income countries or not only for higher income countries, generalizable to both settings. We believe that it is like that, but still there are a lot of limitations, but we can discuss this later before going there. And on doing that, back in 2018, we had the Society of Critical Care Medicine Support Panel formation, with the formation of the Pediatric Sepsis Definition Task Force. And we met Salzburg in 2019 in a scientific seminar where we discussed how can we go forward, and we decided to go for a systematic review to understand the prevailing evidence of pediatric sepsis and their knowledge gap. And we also decided to go for the international survey to understand the ongoing practice of sepsis and what are the needs on the basis of this practice. And we also decided to go for the same kind of studies that were done in case of adult. And for that, we decided to go for a protocol formation. And on the basis of that, in 2020 and 21, we had performed a systematic review to understand the prevailing evidence as well as knowledge gap. And simultaneously, we performed the international review, those who work in this area, their views and their practices and what to need. And simultaneously, we were lucky enough that we submitted the protocol in the NIH, which was funded actually instantly. And in 2022, we published all those things. By 2022, we published systematic review and international survey. And by this time, we also collected data from the different parts of the world, including lower income settings, including Bangladesh. And you can find that this has been done from 12 countries in 6 continents, and we included 35 potential experts, which includes pediatric nursing, pediatric critical care medicine, and also infectious disease specialists, and also pediatric emergency and general pediatrics, and also public health people. And what you can find here is the combination of both higher income countries settings and lower income country settings. And our key guiding questions were here. What can we learn from the sepsis 3 process and data set? And we can debate. In sepsis 3, we have already told that it is a big data driven. We need to perform same type of study, but that in adult sepsis definition study only included data from the higher income countries, from that learning, we thought that we should include data from the lower income countries. And we also thought that it is not only in a special area, not only from ICU, it should also include the emergency department, it should also include general pediatrics. So we have done all in this way. And we have stratified the age group, that is infant, under 5 children, and children beyond 5 years. And we have also included different ethnicity in those data. And you can see that we have shown the schematic diagram here, what we have done, what I have already told that, see that we have done the systematic review, we have performed the global survey, and that by this time we have used the Delphi process, and we have started the study. And but just one thing is there in lower income countries where we do have electronic record system, electronic health record system. We just included those settings because of the fact that is the retrospective data analysis of last 10 years. It is very difficult to obtain the data from a hard copy. It will take years and years to extract data from the hard copies. This is why we try to figure out where the electronic data system in lower income settings, as higher income settings, most of the hospitals have the digital data system. And by this way, we have collected all this data. And if you can find it, if you have published a systematic review in 2020 and survey in 2022, and in 2023, we have further published how we can go forward with the sepsis definition. And by this time, we have collected data, and in 2024 January, and we have published the data that we have extracted from different countries, including lower income setting. And till date, we believe that it is a very robust definition of sepsis, although there are some limitations. We will also discuss what might be the limitations and how we can go forward to minimize those limitations in near future. And you can find that I already told that how we can extract data, but you can see that 3.6 million hospital encounters in children less than 18 years old, and among them we have around 3 million from the development set, and around 6 million encounters from the external validation set. But as a whole, we had 17.5 million encounters with suspected infection, who were observed for first 24 hours. This is very important, that we need to keep in mind that initial diagnosis is to be made, but they were followed up or they were monitored for the initial 24 hours. So initial 24 hours is very important. So, okay, the same thing. So I need to show, I need to show that I have already told that these data represent not only the ICU data, but also from the emergency and the general world, and also a different age group. It represents all the age group and different ethnicity. And if you see the data distribution, you can find that among these data, there was suspected infection was higher in number in higher resource settings compared to lower resource settings. However, if you see the number of deaths in both the settings, it is almost the same. That does mean that there is significantly higher rates of death in lower income settings compared to the higher income settings. And you can easily imagine why it is, because the definition that used to be followed in higher income settings is completely different compared to the lower income setting. This is why we are trying to harmonize this. And this I want to show because there might have some questions at the later. This is why during the data analysis, there was a different modeling. And in one model, there was 8-organ system. In another model, there was 5-organ system. And in 8-organ model, in 4-organ model, there is cardiovascular system, respiratory system, and there is neurological system, and also coagulation system. And you see that in addition to that, there was endocrine, renal, immunology, and hepatic system. And during the data analysis, what we have found that the performance was similar both in the 4-organ model compared to the 8-organ model. And we used it is those who those who are not well acquainted with the statistics. I just want to give you the AUPS, it's the area under precision recall curve, and AUROC, that is area under receiving operating curve. Those both of them used to give you the sensitivity and specificity and positive predictive value and negative predictive value. These are the validation tests for the sepsis. But the prior one, area under precision recall curve, is the better predictor. This is why we used these for our analysis, which was not used in adult sepsis 3 analysis. So we used this one to understand which model we need to take to simplify the diagnosis. So this is why, as both organ 8 model and 4-organ model has the same performance, this is why for the simplification of the diagnosis, we have considered 4-organ model for our diagnosis of sepsis. And you can see that this is the final model that we used for the definition of sepsis. And you can find that it contains cardiovascular, this the respiratory system, cardiovascular system, coagulation system, and the neurological system. And what proposition here after this validation come here that if anyone, there is a 13 score, a 0 to 13 score, if anyone from any system have 2 or more score, that should be diagnosed as sepsis. Even though there is a lot of diagnostic points here, some settings might not have any diagnostics. Even though there are a lot of clinical things, even though the absence of any diagnostics in any settings, if anyone falls within 2 score, they should be diagnosed as the sepsis. You can see that from the respiratory system, those who under mechanical ventilation, their arterial oxygen saturation and FiO2 ratio, that is the PF ratio, less than 400. But in developing country setup, this might not be possible. The later one, that is the arterial oxygen saturation, it is called SpO2, and the ratio of FiO2, we call it SF ratio. If it is less than 292, it will get 1 point. If it is in between 149 to 220, it will get 2 points. If it is less than 148, it will get 3 points. That does mean that if any patient with the respiratory symptom has a SF ratio in between 149 to 220, that patient should be diagnosed as sepsis. Very simple. However, if we want to diagnose whether the patient is septic shock, that patient must have to have at least one criteria from the cardiovascular system. See that in the cardiovascular system, there is score 0 to 6. If that 2 score contains 1 from here or additional 1 from here, that patient should be diagnosed to have septic shock. That does mean that septic shock is a subpopulation of sepsis that needs to have at least one score from the cardiovascular system. So it is simple from that perspective, no doubt. But if you see the coagulation system, there is a 2 score, 2 points, 1 point is maximum 2 points. The platelet is easily done from the developing country setup. There is no problem. But if you see the INR, international normalization ratio, if it is more than 1.3, it is not always done in all developing country setup if there is no special requirement. And D-dimer is almost D-dimer reagent almost nil in the developing country setup, especially in district hospitals, even in tertiary hospitals in our country, and I think also Sahara. Sorry, and also you see the fibrinogen might also be unfavorable. So this is the limitation. But as there is score is 13, we need only 2 score to understand sepsis. And I will show you then there is we also have the table of 8-organ model. If you see that if someone has the 2 score, but from that 8-organ model you find the other scores, you can follow him or her for the progression of the multi-organ failure. So it is by this way it is done. But it is true that without involvement of the cardiovascular system, you cannot say septic shock, but you can still follow whether there is multi-organ failure is going to be here. So we have just emphasized that we need at least 1 point to have the septic shock, which I think for a setup like us is very easy to follow. And that does mean that recently I have seen that 3 letters from different pediatricians, and 1 letter we have received from the Brown University, and they are sorry. No, that is already going to be published. This is accepted. So this is not a big issue. This is why I am disclosing. And a main comment there is that why renal system is not there. It is really a big question. So mainly this one, the renal table is not available in the main publication. This is why it is not visible to all. Renal table is available in the supplementary file, and there in the supplementary file it is shown the 8-organ model. In the 8-organ model, it is shown that the performance of the 8-organ model and 4 organs model are the same. This is why we purposefully excluded renal system from the initial diagnosis of the sepsis. If we follow, the 4-organ model, diagnosis of sepsis is easy for both developing country setup and higher income country settings. However, if someone wants to know what is the condition of the renal system in case of sepsis, if they find the sepsis, they can follow as there is no problem. But in case of developing countries, especially in lower resource setting, we now, government in most of the hospitals make the availability of the pulse oximetry and also oxygen. So respiratory system evaluation should be done there. And in case of cardiovascular system, if we used to have the graph of blood pressure, and it can be done very easily. And also in case of developing country system, and nowadays the support of basic pressure become available, not in all centers, at least in the tertiary centers, and the need for need for the basic pressure support can be identified there. But the blood pressure measurement is very easy for all the clinicians if they practice. So for the cardiovascular system, measurement of blood pressure following the table can be easily done. And this is why we thought that as this performance is okay, we can take this phonics 8 organ criteria for our next follow-up. So our recommendation is that follow a 4-organ model that was published in the JAMA for the diagnosis of sepsis. However, if you want to need to understand this, what is the involvement of the renal system or hepatic system or endocrine system, we can follow this 8 model phonics criteria and how it can help in the diagnosis and subsequent management of the sepsis. It is almost the same, because if there is more involvement of this system, we can say that it is in the advanced stage, but the performance is the same. Because of the mortality, performance is actually evaluated on the basis of the mortality. The mortality remains the same compared to that 4-organ model. That does mean that main mortality, main chunk of mortality comes from that model. That does mean that we need to diagnose the sepsis on the basis of these 4 model criteria. But later, if we want to follow, we can follow this. Yeah, please.
Did you guys look at urine output as a surrogate for renal function?
Yeah, the problem is that as it is the retrospective data, we followed the output, but the problem is that it is not always well documented. So you know that always there is the limitation of the retrospective data, even though there is finding that patient might receive mechanical ventilation, but all the notes are not there. Even from the high-income country data, we didn't find all the documentation. So this is the inherent limitation of that. So I quite agree. This is, we have the scope in future, what we need to refine. We already know that we need to refine the renal system criteria here. Urine output is a big issue, and creatinine might be another thing. But I think that here you can find that in the developing country physician, I have still reservation of that. Here, malnutrition is not addressed, which is a big issue, and mortality from sepsis, you know that in severely malnourished children is enormously high compared to well-nourished children. So we need to address those in near future. And what we have found compared to adult sepsis, which is sepsis 3, that sepsis definition is the main theme. It is the organ dysfunction caused by dysregulated host response to infection. It remains same, but in adult, a scoring system is not like this, which is very much in this pediatric sepsis criteria should make our life more easy. Both the data came from the digital system, but other difference is that in pediatric sepsis definition, we consider the developing country data, which is a huge impact, although there are some limitations. And during the data analysis, we used more precision-based diagnostic model compared to the adult sepsis, and used subcomponent of SOFA criteria, that is sequential organ failure assessment was mainly followed during the adult sepsis definition. But in our analysis, we didn't totally follow this. We just follow the subsegment of what we have already discussed. And the limitations, there are a lot of limitations, but we just want to focus something that, as I've said, the retrospective electronic data always have some missing information that we also have, and it might not have reproducibility of all the settings, but still we think that with the limitation of hard copy data, these data still generalizable in settings where there is electronic data system is available. And in our setting, what I have told that although it is written that anode to be started, but GCS, that is the Glasgow Coma Scale, was not recorded here, or how much sedation was given, it is not recorded here. But this is the things that we used to see everywhere, but still it is more common in our developing country setup. And I have also told the mechanical ventilation, although patient receipt, it is not documented in everywhere. And we also didn't distinguish chronic organ dysfunction, similar to sepsis 3. And advantage is that it's a real world data where critical, where we can use from the setup where we have done this, like this, our icddr setup. We have a lot of settings like icddr where a digital data system is going on. You know that Bangladesh government is trying to make Bangladesh as a digital country, although it is a dream, but still we are on that path. Hopefully, this will help. And it is the 10 years data, which is very robust. But I didn't write here, but I think that what I have told that in resource constraint setting, malnutrition and diarrhea is a big issue. Those who have the malnutrition have already said mortality is enormously high, and those who have sepsis with diarrhea compared to those who don't have diarrhea but isolated sepsis, mortality is much more higher that we have already shown. Yep. And our next step is that identifying these kind of things that we need to go for some studies for the ED setting, especially although we have, we thought that this is generalizable for all settings, but we have found that in ED setting, some patients come with already who are in sepsis, and sorry. Okay.
The battery might have died.
Okay, that's fine. I can still continue.
We
So,
can hear you.
do you hear me?
Yeah.
Okay. So, every definition, when even with the evidence-based, you when it comes first, used to have some limitations, but you can agree with us that till date, this is the most robust definition in pediatric sepsis that we have ever seen. No doubt, still there is limitation. We need to work further on that, especially refining in the developing country setup. What are the tests that we might not need to do? Still, we can go for the diagnosis on the basis of the clinical system, especially in severely malnourished children, also in diarrhea. And we also need to, in future trial, include including renal system to see whether the definition which validated here showed the renal system might not have significant impact, but we need further study to reproduce this result, because it is although it is driven from huge data system, but keep into mind that it is the retrospective data. So we need to validate this in the future trial. And I am sure that you are the future generation who can perform this in near future and help us to make it more robust. Thank you, all of you, for your patient sharing. And I also want to thanks all the task force members of the sepsis definition task force, because they used to meet fortnightly and then monthly since 2018 up to 2023 to make this happen. So thank you for your patience. Now, Dr. I will invite Dr. Farjana Afroze to say rest of the things about sepsis. Battery? Oh, thank you. I'm sorry that I've taken longer time. Please be patient, because
And you can feel free to get more food.
So good day, everyone. And it's my honor to present here and to present a very important topic like sepsis and infectious disease in Bangladesh.
Oh, is the microphone? I think it needs to be closer. That's.
Audible now?
Yeah.
yes, better.
So it's my honor to hear and to present a very important topic on sepsis and infectious disease. And I would like to thank my previous speaker for defining sepsis so nicely. And when we use the definition of sepsis in our clinical practice, it's a very simple definition. And we do not think about that. The many researchers actually worked several years to get this very simple definition. So thank you. So in my presentation, I will mainly focus on sepsis and other infectious disease like childhood pneumonia and diarrhea. So you know that, as you heard from my previous speaker, sepsis is a leading cause of morbidity, mortality, and healthcare utilization for children worldwide. And you already know the definition. It is a clinical syndrome caused by dysregulated host response to infection. Although inflammation is a common response to infection, but in case of sepsis, it becomes dysregulated. So you know that there is activation of chain of events that actually leading to tissue injury, organ dysfunction, and ultimately leading to sepsis and death. So early recognition of sepsis is crucial to ensuring the best outcome in children. Why focus on sepsis? This is an important question. The recognition of sepsis in children is very challenging because of high prevalence of febrile illness among children. They usually have different kind of viral illness and other infection. And also sepsis usually present with some non-specific symptoms like fever, increased heart rate, increased respiratory rate, and like drowsiness. And this actually overlaps some other common infectious disease. That is why also it's very challenging for diagnosis in children. And another important thing is age variability of heart and vital signs. Like for infant, the heart rate 140 is normal, but for older children, it may be is high, too high. So these are the things actually why the children diagnosis of sepsis is very challenging. So as you heard earlier, sepsis is responsible for more than 8% of all PICU admission and causes more than 4.5 million childhood deaths worldwide per year. Globally, 3 million neonates and 1.2 million children develop sepsis annually. Sepsis remains a major public health problem despite the development of standardized guidelines, universal immunization program, and advanced ICU setup. WHO listed sepsis as a key healthcare priority for the coming decade. Timely detection and treatment play a critical role in addressing sepsis. Without prompt intervention, death can occur within the initial 48 to 72 hours of treatment due to refractory shock. That is shock that is not responding to fluid therapy, not responding to vasoactive acid, and this is refractory shock is responsible for 1/3 of all deaths. Multiple organ dysfunction syndrome, that is organ dysfunction of 2 or more organs, where respiratory and neurological failure predominantly contribute to mortality. As you have seen, as you have heard earlier from my previous speaker, mortality for children with sepsis ranges from 4% to as high as 50%, depending on illness severity, risk factors, and geographic location. This pointer. Pointer. Oh, okay. So here you can see the case fatality rates of sepsis. Case fatality rate of sepsis in developed and developing country from 1982 to 2016. This slide is the line for developed countries. You can see here in 1980, the mortality rate in developed country was in between 40 to 50%. But since 1982, it's sharply declining. And in 2016, it is below 10%. And in developing country, there was no data from 1980 to 1990, but in 1990, the mortality rate was above 50%, in between 50 to 60. And it actually also declined, and in 2016, it is below 30%, but still you can see in developing country, the mortality is very high compared to the developed country. And from this data, actually, this data highlight that more than 80%, 85% of sepsis incidence and the mortality is mainly in low and middle income countries. So now the question is, why is mortality higher in developing countries? I think you already know this because there is inadequate critical care capacity in developing countries. And like even in Bangladesh, in icddr, we do not have too many beds for children in our ICU. And also we do not have like expensive equipment like cardiac monitor, mechanical ventilator, we do not have that. So this is one of the limitations or why the death is high in developing country. And another important thing is lack of trained physicians and nursing staff. In developing countries, junior doctors and critical care nurses, they usually do not have formal training. They usually receive on-the-job training. And you know, for early detection, nursing staff is very important. They usually can detect the early deterioration signs. They provide the therapy. So it's very important that they should pick up the septic patient early. And this actually leads to delayed detection of clinical deterioration. And another important aspect is late presentation to the critical care unit, including delay in triage assessment and also late presentation by the families to the critical care unit. And it's because the family, they actually, sometimes because of lack of knowledge, they do not understand that the baby is sick. And also there is like socioeconomic problem, and also is that the transportation infrastructure is not so good. And higher prevalence of malnutrition and other infection also play a very important role in higher mortality in developing countries. So here you can see the lack of diagnostic resources is another important cause of high mortality in developing country. You can see here in the picture, the green line and the green bar and the blue bar, they are representing low and middle income countries. And you can see here, only simple X-ray imaging, complete blood count, blood gas analysis, and non-invasive vital sign monitoring. Only these 4 diagnostic modalities were available in more than 85% of low and middle income countries. The other advanced laboratory methods like renal and hepatic biomarkers, coagulation measurement, inflammatory biomarkers, lactate and other measurements, advanced imaging techniques. Actually, these are not available in more than 50% of low and middle income countries. So consequently, timely and accurate diagnosis of sepsis in children in low and middle income countries actually hampered, leading to delayed treatment initiation and increased morbidity and mortality in these settings. Here you can see the etiology of sepsis in children under 5 worldwide. A recent scientific publication estimated that in 2017, the largest contributors to sepsis among under 5 children were diarrheal illness, neonatal disorder, and lower respiratory tract infection. The same publication showed that the 3 most common causes of sepsis-associated death in 2017 were neonatal disorder, lower respiratory tract infection, and diarrheal disease. However, this is very interesting. You can see, even though the incidence and sepsis-related mortality has declined from 1990 to 2017, you see the leading cause of sepsis actually remained unchanged. In 1990, the leading cause of sepsis was diarrheal disease and lower respiratory tract infection. In 2007, it's that same. And even in 2017, the number 1 cause is diarrheal disease and number 2 is lower respiratory tract infection. This means that we need to work on these 2 diseases to reduce the number of sepsis and death. And here, diarrhea actually a very challenging, especially in patients with sepsis. It's very intriguing when managing a children with diarrhea and sepsis, because children with diarrhea can present with overlapping clinical features that present in both in sepsis and in diarrhea. Suppose here you can see this baby, his eyes are sunken, his mental status is depressed, and you can understand that this baby is dehydrated. So the same findings can be applicable for reasons of severe sepsis, like his hands and feet may be cold, his heart rate may be high, his respiratory rate may be high. So you never know whether it is due to sepsis or due to dehydration. And another important thing is that both dehydration and sepsis can coexist in the same patient. So that is why when diagnosing sepsis, we need to ensure that there is no dehydration. So it is easier to diagnose sepsis after correction of dehydration. And in our practice at icddr, we used to do this. When a patient comes, we first assess whether there is any dehydration or not. We give correction, and then we evaluate whether there are features of sepsis or not. So, researchers at icddr conducted a retrospective study to evaluate the clinical characteristics of an outcome in children hospitalized with sepsis. So the study included around 204 under 5 children with severe sepsis, and they found that 43% children, they progressed from severe sepsis to septic shock, even after recommended fluid therapy and other treatment. And here you can see in the figure, the mortality in severe sepsis was 40%, but when children progressed to septic shock, the mortality sharply increased to 67%, significantly higher compared to the severe sepsis. And another interesting finding is that the progression from severe sepsis to septic shock was more in severely malnourished children. And this slide showing the bacterial isolates from blood in septic children with diarrhea. Among 204 patients, blood culture was positive in 24% cases, and as you see here, gram-negative pathogens predominantly isolated, mainly E. coli and Pseudomonas, which was 23%, followed by the gram-positive one, Enterococcus and Streptococcus. This slide showing the characteristics of children who progressed from severe sepsis to septic shock. I know you have learned a little bit idea what is severe sepsis and what is septic shock from my previous speaker. So here, the researcher found that the patient actually who progressed from severe sepsis to septic shock more often presented with pneumonia, abdominal distension, altered mental status, and malnutrition, which is manifested as nutritional edema or severe underweight. And similarly, as sepsis and diarrhea is a common problem in low and middle income countries, sepsis in malnourished children is also very challenging. Because malnourished children, they frequently present with different types of infection, mainly diarrhea, pneumonia, sepsis, and often progress to septic shock. And in one study, it has been shown that 50% or around 49% malnourished children, they usually present with diarrhea. And another 16% of malnourished children, they develop diarrhea after hospitalization. That is why malnourished children are more vulnerable to develop septic shock, because diarrheal disease is the leading cause of sepsis. And the coexistence of sepsis and dehydration is common in malnourished children. So a study that actually compared mortality in patient with malnutrition with severe pneumonia with severe sepsis compared to those who do not have severe sepsis. And the study found that the mortality in children with severe sepsis with pneumonia and severe acute malnutrition was 40%, which is significantly higher compared to those who do not have severe sepsis, which is 4%. So this indicating that the malnourished children who develop sepsis we need to treat them very seriously. We have to be aggressive to manage this kind of patient. And this slide showing the risk factors for developing sepsis in malnourished children. Here you can see that lack of BCG vaccine, drowsiness, abdominal distension, and acute kidney injury was a risk factor for sepsis in severely malnourished children. So you can ask, or you may have question, why lack of BCG vaccination is a marker here? So do you have any answer? Or you can think about what may be the cause. Anyone?
Probably this vaccination is not
Yeah,
required.
we don't use BCG here.
We do not have BCG vaccine. Yeah.
Is that like MMR? The TB vaccination?
Yeah, many people that were not born in the United States, if you see a little scar, if you see your patients in clinic that have a little scar over the bicep, including like my parents also have those, like many people, it's a routine part of your childhood vaccinations, just like child gets a polio vaccine. It's just standard of care to prevent tuberculosis in the majority of the world where tuberculosis is very, very common.
And funny part is that it is as like as COVID. Even though you're receiving BCG vaccination, you might have still TB.
Yeah.
It just decreases the severity of the disease as well as prevents the TB meningitis
Complications.
and
Like the COVID vaccine.
dissemination.
Not perfect.
Like all vaccines. Before I become political.
Yeah, she has
Yeah.
for
Anyone-
this, she has a very
Yeah,
good
anyone
answer.
have any ideas? I was also interested by this.
Yeah. So actually this indicating that because the parents, the vaccination is free of charge. So the parents actually, they are not taking to the facility for BCG vaccination, indicating that the care-seeking behavior of the parent. This is one of the thing here. And another important that is that several studies has shown protective effects of BCG vaccination. BCG actually protects other illness, particularly from pneumonia, in 50% cases. So this may be the reason why actually lack of BCG vaccination is a risk factor for sepsis in malnourished children. And other, I think you know the answer.
BCG is T-cell mediated, right?
Yeah.
Yeah, that's why.
Yeah, and just if I can add that.
Yeah, sure, yeah.
Recently, there was a systematic review from a Center for International Child Health in Royal Children's Hospital, Melbourne. You probably know the Professor Frank Sham. He's one of the renowned pediatricians who worked in Africa, especially in Papua New Guinea. Given when I'm not the medical graduate. So he showed that heterogeneous impact of BCG. He showed that compared to efficacy of TB, it is much more effective than other disease. So he recommended, though, even though there might have other vaccines in TB, BCG still should be continued in development. Okay, go ahead.
So now the question is, why high mortality in severely malnourished children? We know that clinical signs of sepsis or other infection may not be obvious in malnourished children. This is because they have weakened immune system and they have reduced ability to mount an effective immune response. You know, if we get an infection, we have fever, but malnourished children do not have that capacity to produce fever. So that is an important cause because their signs are masking, the signs of infection are masking. And another issue is that death primarily is due to infection or dehydration, but sometimes there is no other identifiable cause. And researchers have shown that cardiac dysfunction may be associated with this unexplained death, because in malnourished children, their left ventricular muscle mass is reduced and they have significantly lower ejection fraction compared to the healthy counterparts. So that is why WHO identified some simple criteria or some simple clinical features to identify sepsis very early in severely malnourished children. These are actually very simple. We can identify these during our bedside examination, and these include delayed capillary refill time more than 3 seconds, weakened fast pulse, cold extremities, reduced level of consciousness. And WHO recommended that any severely malnourished children with signs of sepsis should be signs of septic shock should be treated aggressively. But we have to prevent sepsis because we know that prevention is better than cure. So this is the best way to reduce the risk of infection or risk of sepsis is avoid infection. So good personal hygiene like hand washing, preparing food safely, avoid unclean water or unsanitary toilets, getting recommended vaccines, and improving nutritional status of children and breastfeeding, promoting breastfeeding. By adopting all these, we can avoid infection. And sepsis, for preventing sepsis, we need to treat infection early, and we need to implement effective rules for infection prevention and control, and we have to use appropriate antibiotics. And this was all about sepsis. Now I will discuss a few slides about pneumonia and childhood diarrhea. Pneumonia is an important cause of morbidity and mortality. Globally, 1 child per 71 children every year suffers from pneumonia. And the occurrence of pneumonia is higher in South Asia, West and Central Africa. Although the mortality from lower respiratory infection significantly declined by 56%, even today, a child dies of pneumonia in every 43 seconds. So pneumonia is one of the major killers of children under 5 years of age. A recent study shows that investigated the etiology of pneumonia, and they found that in infants and children, the virus is responsible for pneumonia in 61% cases. And 27% of pneumonia is bacterial origin, and 6% is due to Mycobacterium tuberculosis, that is tuberculosis. But in severely malnourished children, the etiology is a little bit different. As you can see here, a systematic review found that in severely malnourished children, the #1 cause of pneumonia is Klebsiella species, which is around 26%, followed by Staphylococcus aureus, which is 25%, and followed by other pathogens like Streptococcus pneumoniae and E. coli. And a recent study found that Mycobacterium tuberculosis is a very important cause of pneumonia in severely malnourished children. And the prevalence of tuberculosis among severely malnourished children was almost 23%. So as pneumonia is the leading cause of death, so WHO recommended appropriate use of antibiotic and other supportive therapy like use of oxygen to reduce the mortality of pneumonia in children. But in low and middle income countries, despite this treatment, the mortality is very high. So researchers at icddr, they conducted a clinical trial in 2011 to 2015, and where they compared a low-cost, locally made bubble continuous positive air pressure oxygen delivery system with low-flow oxygen therapy. And they found that bubble CPAP was found to have 75% reduction of mortality compared to WHO standard low-flow oxygen therapy. And after this trial, the Dhaka Hospital of icddr adopted this bubble CPAP, and now this is the one part of the standard of care at Dhaka Hospital of icddr. And after adopting bubble CPAP, we found that the overall cost of oxygen consumption in Dhaka hospital significantly reduced from $30,000 in the pre-trial period to less than $10,000 in the post-trial period. And recently, a cluster randomized control trial determined or assessed the effectiveness of bubble CPAP compared to the low flow oxygen therapy. And the study was conducted in 12 district hospitals in Ethiopia. The study enrolled around 1,200 children, 50% in the bubble CPAP group and 50% in the low flow oxygen group. And the study found that bubble CPAP was associated with 76% reduced risk of treatment failure, and also it has mortality benefit, that is, no children died in the bubble CPAP arm, but all 6 children died in the low flow oxygen therapy arm. And the study concluded that bubble CPAP can be implemented in general hospitals in low and middle income countries with a survival benefit in treating childhood pneumonia and hypoxemia. But the study also highlighted the importance of close monitoring, but especially by the nursing staff and also by the physician, to ensure that the bubble CPAP is working, because it may be detached from the oxygen source or the tube may be blocked. So you need to monitor the patient meticulously while the baby is on the bubble CPAP. Now I will discuss about diarrheal disease. This is the third leading cause of death in under 5 children, and in resource-limited countries, infant experience 6 episodes and children experience 3 episodes of diarrhea annually. And diarrhea is defined as passage of abnormally loose stool 3 or more times in 24 hours. The leading risk factors for diarrhea are childhood bursting, unsafe water, and poor sanitation. So in Bangladesh, there are different types of diarrhea, like acute diarrhea. It starts acutely and persists for less than 14 days. We call it acute diarrhea. So it can be watery, like watery in consistency, and it may be due to virus and bacteria, or it can be invasive or dysentery, that is presence of visible blood in the stool. It can be due to some organisms like Campylobacter, Shigella, and enteroinvasive E. coli. A study conducted published in 2015 in Lancet Global Health, they investigated the etiology of diarrhea in community setting in children 0 to 24 months. And they found a large number of pathogens was identified in the stool of this patient. And they found that the infection began soon after birth. So here the upper panel is showing the pathogen burden in children aged 0 to 11 months. And they actually identified 22 pathogens in this age group. And among children 12 months to 24 months, 25 pathogens were identified. So in the first year of life, the most common organism for diarrhea actually are viruses like norovirus, rotavirus, astrovirus, and other organisms like Campylobacter and Cryptosporidium. And the study highlighted that in the second year of life, the most common pathogens are Campylobacter, norovirus, rotavirus, astrovirus, Shigella, and enterotoxigenic E. coli. And this slide showing the different causes of diarrhea in Dhaka Hospital of icddr, both in urban and rural setting. The green bar actually representing the urban setting, and the red bar representing the rural setting. So among children less than 5 years of age, the most common cause of diarrhea is rotavirus, as you can see here from the graph. And for older children, like more than 5 years, the most common cause actually is cholera. It is around 18%, followed in urban setting, followed by E. coli and Campylobacter. But in rural setting, the prevalence of cholera is a little bit less. In the Shigella and Salmonella, they actually main cause of diarrhea in older children. So the major complication of diarrhea is dehydration. We can diagnose dehydration using some very simple clinical characteristics. Here you can see the 5 characteristics. We use these characteristics to categorize the degree of dehydration in a child. that is no sign of dehydration or some dehydration or severe dehydration. Here you can see a baby with severe dehydration. So you can see his mental status, he's lethargic. And if you can see his skin pinch. It's actually if you pull the whole thickness of the skin, it actually leaves as it is. So it's not going back quickly. It means that his pulse, if you feel his pulse, is actually uncountable or absent. So it's indicating that the baby is severely dehydrated. Oral rehydration solution. It is the cornerstone of therapy for severe or for dehydration. ORS was established back in 1970s, around 50 years back. It is a simple mixture of salt and sugar dissolved in water. So you see a large part of the research on development of ORS took place at icddr. The first successful trials of ORS was published in the Lancet in 1968. And it has been recognized that the ORS development is one of the most significant medical advancement of the 20th century. Its effectiveness and low cost have saved millions of people, well, particularly children in developing countries worldwide. Here you can see the baby, actually children, they can take ORS very easily. An older child, he can take ORS using a cup or a glass, and an infant less than 6 months, he can take ORS using a dropper. Here you can see the mother is giving ORS to her baby. And another important management for diarrheal illness is zinc supplementation. Zinc is important for cellular growth, cellular differentiation, and metabolism. And benefits of zinc include, especially during the diarrheal episode, it reduces the duration and severity of diarrhea and prevent subsequent episodes of diarrhea. And these two simple management, that is ORS and zinc supplementation, actually reduce the mortality of diarrhea from 4.5 million to 0.6 million. And Dhaka Hospital of icddr is used to treat thousands of patients each year. And in 2018, a large diarrhea epidemic broke out in Dhaka city and the adjoining area, which continued from April to May. So during that epidemic, usually in Dhaka hospital, we around 300 to 500 patients they used to visit at Dhaka hospital. But during that epidemic, around 1,000 to 1,500 patients used to visit every day. So this was the actually largest epidemic in the history of icddr in the last 60 years. So modeling has shown that if the icddr Dhaka hospital were not present, more than 70,000 lives could have been lost during the 2018 epidemic. So thank you so much, and I'm deeply honored and pleased to attend this Galkin lectureship series organized by the Brown University and the teams. Thank you so much. Do you have any question?
Thanks so much for your patience.
All of them are so passionate.
I hope this is helpful. I know first years you guys are on your infectious disease block. So some of these terms are very technical. So especially the pathogen names. But I think the impressive thing is that your institution and these researchers have done some of the biggest clinical studies in the world, and doing it with